Representative Wilson, Representative Bowling, Representative Bray, Representative Heverin,
Here.
Representative Poor Moser, Representative Petrie, Representative Fleming,
Present.
and Representative Williams presiding.
Here. All right. Next, do I have approval for the we got a motion and a second. All in favor?
Aye.
Anyone opposed? Motion's carried. So today, I don't want to be offensive to any of the presenters today or anyone in the crowd, but we have a very full agenda today. So we may have to speed you up sometime. So please don't take offense to it. We have to be out of the room at a certain time. We have a lot to cover today, and we want to make sure we get to it. Okay, first today we have Dr. John Langefield with Public Health Commissioner and Mike Tuggle to present on a couple of public health budget requests. And again, we're focusing today. We've been through this presentation a couple of times, I think, and had some very good discussion about it. But, you know, we're kind of drilling down into the budget section of this and what that additional budget looks like, those requests looks like. And we're looking for duplication, sustainability, performance type things as we move forward to make decisions on the budget. So if you would introduce yourself for the record, and the floor is yours.
Yes, good morning, Mr. Chair and members of the committee. My name is John Langfeld. I'm the serving commissioner in the Department for Public Health, and I really thank you for the opportunity to be here today and share some information. I'm going to begin with information on our Rural Health Transformation Plan, and I'll move through that relatively quickly, and then our director of our laboratory will follow me, Mr. Johnson. You know Mr. Mike Tuggle. Many of you have seen him for years. So I'm going to begin with the timeline. This timeline was brisk, to say the least. It was somewhat unprecedented. You can see here the NOFO dropped on September 15th, and it was due. We delivered it on November the 3rd, which gave us about 6 weeks to really articulate a transformation plan. Moving forward quickly then, we're now in the second week or the first week of February. We're still finalizing budget numbers with CMS. We anticipate that will be resolved hopefully soon and unrestrict the funds. But we haven't been idle. We've stood up a team, implementation and support team, in active process of that. We are actively planning on how we'll deploy our strategy as quickly as the funds are unrestricted. I'd like to pause and briefly thank all of the partners that had tremendous response and activity to an RFI we released. We had about 60 organizations across the state that submitted formal written responses, and we had many more than that submitted, and probably around 300 different ideas of things we could consider. And so we've assimilated those and coalesced around commonalities and as we developed our program. We also had about 48 of them that signed official letters of support when we submitted our application. So let's talk about the award. The award was announced December 29th, and as you see here, our award amount was $212.9 million, just under $213 million, which was the first of 5 funding periods that are anticipated. And you see in the graphic that that this really is the 11th highest award in the country, which I think speaks to the strength of the submission itself. And so we were very pleased with that. So I want to talk a little bit then about what we're focusing on. A lot of these are not surprises to anyone because we all know the challenges. But as we sought feedback, as we considered where we wanted to start, we coalesced around 5 different areas. The first is we're all aware that we have about 46% of our counties that are maternity deserts. and we anticipate that that actually may get worse in coming years. So our first area of focus is on maternal and infant health. The second area that we are focused on is integrated, we call it crisis to care, integrated EMS and trauma response that seeks to address a lot of the fragmentation we know exists in our emergency preparedness and response. The third area really focuses on behavioral health and substance use disorder. We call it rapid response to recovery. And this builds on an evidence-based model that has already started, but we're going to build on that and expand on it and deploy across the state in different regions this opportunity as well. The next is an area that we all know has been an issue in Kentucky for many years, and that is how do we address issues in oral health? We call it rooted in health. And the last one really begins to look at chronic disease. If you talk with folks, all of us are aware that there's lots of different chronic diseases that are prevalent in Kentucky. In fact, most people who have chronic disease have more than one, have multiple. So where do we begin? We have chosen to begin with obesity and diabetes as an area of focus and looking at the full continuum from primary, secondary, and tertiary strategies that we would deploy and learn from. This is meant to be a learning system. Now, I would point out that all of these areas are not meant to be independent silos or projects. They're meant to be something that are integrated together and have some cohesiveness and are built upon a foundation of innovative technology and what I like to call robust data informing infrastructure. One of the things that I want to highlight is this opportunity. CMS really constructed it to make us truly think differently. What they said was, this is about transformation. It's about big innovative ideas that are evidence-based. They've given a 5-year time period for us to deploy the initial strategies. Early wins are going to be really critical, and I'll talk a little bit about that, more about that in just a minute. And there's risk involved. This is not a traditional funding grant, so to speak. So I'll talk a little bit about this. One of the things I want to highlight is what it's not, though. This is not meant for ideas that are unsustainable, meaning everything we do, all of our strategies, all of our work, we have to look through the lens of sustainability. Because if it's not sustainable past 5 years, then we're wasting a lot of energy and money. And so it's not meant to be unsustainable. It's not more of the same, and it cannot be used to replace or duplicate funding or change fee schedules. Now, one of the things that I'll finish up with is just this funding comes with certain guardrails and restrictions that we really have to be aware of. And some of the restrictions I'll point out very quickly because we get a lot of questions about them. So, for example, we can't pay for new construction. We can't pay salaries of clinicians. We can't pay for independent research and development. We can't pay to replace electronic health records. And we also, anything that is currently billable and payable are not services that we can pay for. So we can't augment fee schedules or create new payment methodologies that supplant what's already existing. And the way I would sum it up is this is a tremendous opportunity for investment in our rural communities, but it's not a blank check. These restrictions, so for example, we will receive funding and we will use it in deployment of our strategy. But if we don't do what we said we were going to do, then that money can be clawed back. Number one. Number two is if we don't progress and do the things that we wrote in our narrative, that will also affect subsequent funding levels in the different periods of time. So there is significant risk, even though there's opportunity. We are going to need to be very diligent with it and focused, and we certainly plan to do that. So with that, I'll pause to see if you may have additional questions.
I do. Let's first start talking about additional budget requests from CFHS. You did your request early on in the year before the approval of this transformation project. What are there any duplicate funding areas, and if they are, what are those areas that we can look at?
Yeah, you mean relative to the rural health transformation?
Yes, correct.
There are no duplicates that I'm aware of. We actually tried to be very diligent about looking at that, and in fact, the ABRs that we reviewed, I think, were completely independent of this process.
Okay. Are there any? Could you kind of talk about one-time funding versus sustainable funding, and
Yep.
What you got into that program?
Yeah, so again, one of the foundational pieces of this is sustainability. And so this is really meant to be an investment for us to think differently, to invest in technology, to invest in new ways of thinking about care. There were actually 5 sort of foundational pieces that CMS identified. Number 1, they said make rural America healthy again. 2, as they said, there are issues you need to focus on workforce and the pipeline around workforce. 3 is you need to think about the way we deliver care and think differently, because we know there are gaps. We know that there are loss of resources. Think differently about how to respond to people in rural communities in a different way. The 4th was how do we think about technology? We've got amazing technologies, but how can we use it more effectively? Yeah. Telehealth, for example, remote monitoring, connections with what we call centers of excellence, the engagement of different data sets. Data is sort of the lifeblood of improvement. And so how do we remove the friction points around the flow of data, for example? And the 5th, just to put the foundation, was sustainability. And so as we think about that and those delivery models, how do we think differently about paying for them? What's the economic model that's different than it is today that'll make it sustainable even after the funding is gone?
Okay, just so I'm clear on the question I asked you about earlier, your ABRs, your additional budget requests, would have no correlation with what came out in the Rural Transformation Fund?
No
right?
correlation.
Okay. All right, I think we have a question here from Representative Wilner. Go ahead. You had the floor.
Thank you, Mr. Chairman. Just, and I know we have very limited time, but I'm interested in knowing a little bit more about the decision-making process, how the priorities were chosen, and I guess specifically, and I like the things that you've identified are all incredibly important. One of the things I see missing is dealing with an aging population and the specific challenges there for caregivers, for loss of mobility, for dementia processes, for all of the associated. We do have an aging population, and I don't really see anything in here to address that.
Yeah,
Doctor, if I would, before we start, remember we're focusing on the budget piece of this today. So if you could be brief on touching on, I know you could probably talk in depth about it, but if you would, we're focusing on that, and if you would be brief on it.
Yeah, I'll try to be brief. Very important question, though. I'd be glad to explore it further. But let me just say that we did not ignore. We know we have an aging population. So if you look at any of these areas of focus, whether it's obesity and diabetes, whether it's oral health, whether it's behavioral health, substance use disorder, probably with the exception of maternity and infant care, all of these still consider the full continuation or spectrum of ages, if that answers your question.
Next, we have Representative Johnson. You have a question? You have the floor.
Thank you, Mr. Chairman. Very quickly. Assuming that the funding request is approved and you guys implement the program, how will you be able to quantify and then report back the successes, or the truth of the matter is sometimes things just don't work, the things that didn't work. Is there any an accountability plan?
Yeah, absolutely. Thank you for that question. Actually, as I mentioned, this was really built, and CMS intended for there to be accountability in it. So what they required in our application was for us to be as specific as possible about what our metrics were going to be that we intended to accomplish, what the timeline of those metrics included, and that's what we're going to be measured on. And so, and in fact, graded to see if, number one, the money gets clawed back, or number two, we get funded appropriately going forward. So absolutely there, and you'll, if you look at our narrative, all of those metrics are in there.
Good deal. Thank you, Mr. Chairman.
And I'm assuming that some of the metrics that we talked about are that you applied for are avoidable, hospital stays, those type things, or do you have metrics on those things?
Yes, there are two kind of different areas of metrics. One is how do we execute, and we're using a methodology called OKRs, Objective and Key Results, which actually Dr. Oz and his team uses as well. Yeah. But the second is how do we think about things like activities. Readmissions is a good example. Yeah. Readmissions typically, historically, has been more of a lagging indicator. We look back and say how many we have last year or the year before. We have reoriented that a little bit, because in the world of trying to continuously improve, we need more rapid cycle feedback so that we can course correct. So we need to be looking, for example, a leading indicator may be how many readmissions happened last month, not last year, so that we can see if there's some distributions or course corrections we need, if that answers your question.
It does, thank you. Next on the list is Representative Fleming.
Thank you, Mr. Chairman. I know you went through a very rapid process in order to get this information together and submit it and get the approval from CMS and the federal government and so forth. During your planning process, I've got to, based on my experience, I've got to believe you went through and assigned or estimated costs for each one of these components within your plan. And I want to know exactly what each of these components consist of, and even if it's an estimation, that's fine, but I like to know what that is in those regards. In addition to that, in your application, you talked about the navigators, and then the navigators are already being funded around $18 million. So there's a duplication in there that I can see at this point, unless you're totally scrapping navigators and doing something else and funding this through the rural health into this particular program. So I need some clarity, because I understand what you're saying, but I'm finding a little bit of more duplications on what you're indicating.
Yeah. Well, a couple things to address your second question. We are, as I said, being very diligent. Navigators, I don't recall that we've written in. What we have written in,
they're in the plan.
What we have written in are, for example, community health workers, which are sometimes covered in different ways. We would not supplant or duplicate anything that exists today, but we would understand how we can augment that in some way. The second thing, relative to your question about the budget itself, absolutely right. We did a very detailed budget. In fact, down to line item detail that actually we had to roll back up and submitted a budget narrative to CMS. Part of the delay or restriction so far is that, fortunately, we were awarded above what we budgeted. So a lot of this delay has been for us to adjust that budget. But what you will see, we will be releasing that budget narrative, components of it, so you can see more detail as soon as those restrictions are lifted.
So when do you plan on releasing that?
As soon as we finish the process with CMS and they approve, then we can plan on releasing.
So can you not give us any type of indication what they are, even though it might be one page line item to the chairman, so we can get out? Because what I'm concerned about, that we're going to go down this plan, and we've got 5 years in order to go through this process, and then, to be frank, the governor's going to be gone in 2 years, and we're going to be stuck. The General Assembly is going to be stuck trying to deal with a lot of stuff. And so if we have an understanding of what the costs are right now, even though we haven't finalized it in terms of in the spirit of cooperation, collaboration, We want to try to work with you to go through this process. So is that possible? We can get a better understanding of what those costs are. So it could affect this budget to some degree, because we don't want to duplicate. We don't want to allocate something out there, and that you're being taken care of this application. Do you follow me?
Yeah, absolutely. I certainly understand and understand the need, and I'll be glad to explore that. What I am anticipating, our last revision was the end of last week. We actually are actively waiting, and I'm hoping really any day we'll get the final sign off on that. But in the interim, I'll be glad to explore that. I just don't have an answer for you right now.
Okay. All right, thank you. I think we'll move on now to the we have a couple of members or a couple of folks with us here today to talk about the new central lab expansion. And if we could talk again, we kind of went through this and talked about it a little bit. And what we're really trying to drill down into is the budget numbers and again, duplication or what's happening now, what isn't happening, those type things. So you go ahead and introduce yourself and you have the floor.
Kentucky State Public Health Laboratory. In July of this year, I'll have 27 years of state government experience. All 27 have been within our consolidated laboratory. So it gives me a pretty good idea of our current capabilities and also the limitations that we're facing right now. I think most of you guys know that DLS is a high complexity laboratory, reference laboratory for the state of Kentucky. We provide specialized testing and response efforts, including response to bioterrorism agents and toxins. So currently, we operate in a 35-year-old building that has some serious impediments that cause us, or that limit our ability to, respond to needs. Some of these unresolved deficiencies could potentially lead to lack of testing that we need to do, service disruptions, a potential employee workplace error or injury, and the loss of mandatory accreditation that we need to have in order to provide the services that we do. The challenges that we face, kind of fall into four different main buckets. So like the aging infrastructure that we currently have with the building itself, the obsolete and mission critical equipment that are end of life, the extensive deferred maintenance that we've faced throughout the building, and the insufficient and poorly configured work areas and square footage, and that's largely just because science has changed, technology has changed, and so the laboratory hasn't been able to be reconfigured. The proposed new laboratory is needed to prevent these disruptions and to ensure that we can provide the services that we're required to provide for the citizens of Kentucky. A lot of these services that we provide there is no other in-state alternative to what we do. So this includes newborn screening for the 52 to 53,000 annual live births that we have in Kentucky. We provide all of the genetic testing for these children, these infants. We also are the only federally approved select agent program and biosafety level 3 testing facility, and so that includes your white powders, your anthrax, your pestis, your botulism. Those are the items that come to us that have to be tested immediately. Also includes animal necropsy services, which largely we're looking for the identification of the fatal rabies virus in these animals to help to protect the citizens. We also provide specialized viral, bacterial, and fungal identification, culturing, and then subtyping through genetic sequencing. Again, genetic sequencing is something that was not even thought of 30 years ago, at least not in public health. We provide a wide array of environmental and food safety testing that we are mandated by federal and state law to conduct, and DLS is the only facility in the state that can do a lot of this testing. One of the things that people don't realize is that during pandemic events or high stress testing capabilities or positions, we actually validate the other state laboratories, the other in-state laboratories in the state. So we're talking about our hospital systems that need to bring on new technology. We'll help them do that. The final piece I'd like to bring up as to what our obligations are is we work as the primary and sometimes only response to rapid emerging infectious diseases such as Zika, chikungunya, Ebola, pandemic influenza, and of course pathogens like COVID. Those will fall to us. Then, if capable, we'll help validate those other laboratories. So you can see that a laboratory like DLS is fundamentally different than what you would consider with a normal state office building or even your typical hospital laboratory. We provide specialized boutique testing services that have to be done somewhere, and we're the laboratory that does them. When new legislative requirements are brought up, so 902 KAR 45031, which governs the testing and sampling of cannabinoid samples, those increase our testing obligations, so that is something we've been asked to do. We do not have the square footage or the capability to do that in the current facility. I think that, in order to remain compliant, we do need a modern, purpose-built laboratory. So should we become unable to operate, any of the testing services we're unable to do would have to be forwarded outside of the state to other facilities at additional cost to the state, as well as, increased timeliness. Increase as in it's going to take a lot longer for us to get those samples tested. So following a comprehensive feasibility study in 2020 or 2021, it was determined by the vendors that we contracted with that the citizens of Kentucky and the state do need a new public health laboratory. We went through multiple options, and ultimately it was decided that the best decision would to just build a new one or an adjacent building connected to the current one we have. So at that time, we were able to gain approval for funding for the design phase, which was over $35 million at that time. So for the last several years, the DLS team, as well as the contracted architects that are specialized in laboratory builds and their consultants, we've moved through Phase A, which was the schematic design, to Phase B, which was design development. We are currently in Phase C, and we're actually at the tail end of Phase C, which is the creation of the construction documents. So we're expected to have Phase C wrapped up in mid-April of this year. And with approval of the construction funding, we would then move into Phase D, which is bidding and construction, with potential groundbreaking in or late summer or early fall of this year. So as you can see, the design portion is nearing completion. The project itself is actually a little bit ahead of schedule, firmly on schedule. And one thing I'd like to note is it's important to know that you can move to the slide forward. Sorry, thank you. It's important to note that other agencies that are currently housed within our consolidated laboratory, they are also in critical need of square footage, and they are hoping that this build is funded so that they can move into the space that we vacate once the laboratory is operational. And I'd like to say that this is a capital project. It is moving faster than anticipated and moving very well. We've done a great partnership with all people, including finance and the architects that we're working with. So in closing, I'd just like to thank the governor and the General Assembly for their consideration of this request, and just thank you for your interest in what we're doing.
Thank you. I appreciate your presentation. So could you talk to me a little bit about, it sounds like we're going to build a facility and you're going to have another one, or the current one, still in use. So what costs is that adding on a long-term basis with that? Do you have those numbers with you?
I do not have those numbers. And I don't think, that would be probably a finance question. You're probably correct. There will be some. We do have a plan to move from the current facility to the new facility fairly quickly. There's actually part of the contractor with the architect consultants. They have people that do this on a regular basis. So we've started considering this. There will be some additional costs. It's probably incorporated into the budget request that we've set forward.
And when you're doing some of your testing and services, do you have private partnerships with anyone throughout the state, or maybe in an adjoining state that they do similar testing? Or if you have a failure, what do you do from that point?
So we are part of the Southeast Consortium. So the other Southeast states, we have an agreement, memorandum of understanding, where we help each other out. Mm-hmm. Minimal testing if it's needed. We kind of respond and help each other out. We do have some agreements with the universities, the larger universities here in Kentucky. It's probably not anything on paper, but we help them, they help us when necessary. But as far as if we were to go down, we would immediately reach out to the Southeast Consortium and see who's capable of helping us out. And we do drills like this regularly every year.
Okay. Any other members have any questions? Representative Johnson, you have the floor.
Two very quick questions. First question, I just want to clarify, did you say that you will keep this facility and have a new facility? Is that what I've heard?
So the other tenants, so we're in a consolidated laboratory with 4 or 5 other divisions. They're also in critical need. So as we vacate the square footage that we're in right now to move to the new laboratory, they are ready to move in and take that space. So the current laboratory itself will not, it'll still be used, and the Department for Public Health will be moving into the new laboratory.
Okay, thanks. That's good clarification. And then second question, very simply, what is the ask?
It is right around $276 million, and that's, as I said, the design phase was a little over 35, close to $36 million for the design phase, which I think Mr. Tuggle said that we've expended about half of that so far. The other $276 million is for the build itself.
Okay, thank you, Mr. Chairman. Thank you.
All right. Thank you, gentlemen. Appreciate your presentation. And next up, we have Commissioner Lisa Dennis and Misty Salmons, Budget Director with the Department of Community-Based Services. And we're going to talk a little bit about budget requests as they relate to SNAP, relative and fictive kid caregivers. Thank you all for coming today. If you would identify yourself for the record, and you have the floor.
Good morning. My name is Lisa Dennis, and I am the Commissioner for the Department for Community-Based Services.
Good morning, Misty Salmons. I'm the Director for the Division of Administration and Financial Management for the department.
All right. Thank you for the opportunity to be here this morning to talk about a couple of items within the governor's recommended budget as they relate to SNAP and relative and fictive kin. So first, we'll start with SNAP. Within the governor's recommended budget, there was funding for 2 new requirements as part of H.R. 1, House Resolution 1 that was passed into law July 4th of 2025, made additional requirements of all states, not just Kentucky, but all states, as it relates to payment error rates and SNAP admin costs. So for the first time, this H.R. 1 requires states to contribute a percentage of the benefits issued if their payment error rate exceeds 6%, and that's based on a 5, 10, or 15% of the benefit amount, again, based on what that payment error rate is above 6%. And the other thing that H.R. 1 did is it increased the SNAP admin costs. Previously, that was a 50-50 split between the state and the federal government. That now has changed with implementation of H.R. 1, and that will be 75 state and 25% federal. All right, just real quickly, I think we all know what SNAP is, the Supplemental Nutrition Assistance Program. It provides monthly benefits to eligible low-income families in Kentucky to help purchase food and prevent hunger. I won't that quickly. And just here, you can look and see what the numbers look like for December. So it's just a snapshot of 1 month. In December, we had over just under 280,000 households that were active within the SNAP program, and just under 600,000 individuals for $99 million issuance for that month. And the average SNAP per household amount is $343. And beyond addressing hunger, SNAP is also a significant economic driver. It helps support our grocers, our food manufacturers, and our agriculture, our local farmers. And you can see here on this slide the number of retailers in Kentucky that accept SNAP. So, as we talk about HR1 and the budget request, again, the first one is around the SNAP administration costs. So, again, like I said previously, the cost to operate the SNAP program had been shared 50-50 with the state and the federal government. HR1 changes that to 75% state, 25% federal. And again, this is a condition to operate your SNAP program, and it is required of all 50 states. And you see here in state, and this is effective, HR1, this component is effective beginning in federal fiscal year 27. So, so you'll see the amount, the increase for Kentucky for state fiscal year 27, which is 9 months, and then state fiscal year 28, which is a full year. The second piece of HR1 that was in the governor's approved budget was around, or recommended budget, was around the cost share if a state's payment error rate exceeds 6%. So currently in Kentucky, our payment error rate is at 4%, and we do not anticipate needing an appropriation during this budget cycle for that cost share. This goes into effect in federal fiscal year 28, so October of 27, and states can use either their federal fiscal year 25 or 26 payment error rate when that implementation begins. So right now, our payment error rate is at 4%. The QC process that determines that payment error rate, the case reviews are completed in the auditor's office. So those case reviews get completed there. They send their reviews and their data up to F&S, who does the final review and again ensuring the accuracy of those reviews, and will issue states' final payment error rates. And that data comes out in June, end of June, but we just received the last month of reviews from the auditor's office, and they have Kentucky's payment error rate at 3.99% for federal fiscal year 25. And those reviews always closely align, so unless something went wrong somewhere, no, that we don't anticipate there being any additional cost for this budget.
Just real quick, now in 24, did I see correctly, it was about 9%?
Correct, it was in 24.
And then, so, I mean, it's obvious that we're seeing a trend going down. Mm-hmm. Are there any things you've put in place that have caught those things, or what are you doing to make sure that continues that direction?
Yes, thank you for the question. So in 2024, all states seen a higher payment error rate. I think that was pretty much across the board. There was a lot of things in 2024 that was impacting payment error rates. The biggest was coming out of the pandemic. During the pandemic, there was a lot of flexibilities, waivers in place that allowed states to waive certain requirements and do things differently. And as those requirements went away, we seen some increase in the payment error rates. And then there was staffing also. At that point, we were just coming out of a significant staffing turnover problem. And so again, there were a number of different things that impacted our payment error rate in 2024 that it's been corrected. Our review process, our quality assurance process is rigorous. We complete within the department a number of different reviews and checks, starting with our frontline supervisors, and then within our regions, our program specialists also do case reviews. And then we also have a team in central office that completes those case reviews in addition to the auditor's office and USDA. So as we, DCBS, are completing those reviews and getting feedback from the auditor's office, we take that information. We do targeted reviews on cases that we know there are more likely to have errors. And again, we target those cases, we review, we do additional training and supports to our staff. And so again, we have seen a great improvement in our payment error rate.
I appreciate that. It sounds like monthly is pretty much the standard in your office. Is that what it sounds like?
For the reviews?
The reviews?
Yes.
Yeah.
Yes, there's reviews going on every month.
Okay.
Okay, so like like I said a second ago, we are not anticipating a need around the payment error rate if things remain the same as we implement HR1. So let's talk about SNAP admin a little bit. SNAP is a complex program and has a number of different things that impact the SNAP admin. But here you see the four primary areas. Personnel is the largest piece of the SNAP admin cost. That supports staff salaries. That again, our staff is who is responsible for that payment error rate, and have done. I have to give a shout out to them. Our family support staff have done a phenomenal job in ensuring that payment error rate stays low. It also includes contracted staff, training, and then things that influence the personnel cost. Of course, our salaries, retirements, changes at the federal, state level, complexity of the program, and then of course just volume.
If we could just speed to the part on the summary, if you don't mind. I don't want to be rude, but
Sure.
when you're talking about this error rate and some of the modernization, nothing in your budget request would reflect anything other than the payment distribution has increased. Is that correct? Let me reword that. So anything that you ask for in the budget, the ABRs, has nothing to do with a modernization technology, or it's just basically if it went from 75 to 25, so on and so forth.
It's to comply with HR1. That
Yeah.
admin cost increased. Yes.
Okay, so there's nothing else, no bells and whistles or anything in there.
No,
Okay,
no,
thank you.
No, and those amounts again were on the previous slide at 43, I think, million for federal fiscal year 27 and 53 million for
58 million.
sorry, 58 million for federal fiscal year 28. And again, that's based off of the governor's recommended budget. I know we have the House recommended budget, and those cuts may change those estimates. We may see increased need.
Okay. Thank you very much. I think that covers everything we needed in that. We need to move on to the next question. Can I ask a TANF question
Sure.
really fast?
Yes.
So, just really fast, let me find my note here I made. I was doing a little homework on TANF, and I found under TANF rules that there's some other maintenance of effort funds that are referred to as a separate state program. It's up to a certain percentage of the TANF amount. How much of that, or do we have those funds, and if we do, how much are those? Are they reflective in any of your budget information and so on?
So the way we do the TANF MOE, we're allowed to use other dollars spent for childcare.
Mm-hmm.
So state dollars up to a certain percentage that is appropriated for the childcare services, we can use toward the MOE for TANF.
Okay.
Typically, it's about $56 million in regular TANF general funds, and then about $20 million that we're allowed to use from childcare to meet that TANF MOE.
Okay, and are those reflected in anything that you present? Usually in the, probably not in here, but could you get me the numbers, exactly what those numbers are?
Yes.
And get it back to the committee.
How
if you
far
would?
back would you want me to go?
Just a couple of years will be fine.
Okay, yeah.
Thank you. All right, thank you. Let's move on. We have a question from Representative Wilson, real fast.
Yes, thank you, Mr. Chair. I just want to clarify, and I think I know the answer to this, but in case anyone's watching or at home. So we are just referring to the money you're referring to is the administration of SNAP, not the actual program itself, not the benefits.
Correct.
And so those program benefits, for example, food stamps, who pays for those? Is that federal funds?
Yeah, that's 100% federal funds.
Okay, thank you very much.
We have one more question from Representative Fleming.
Thank you, Mr. Chairman, for your indulgence. Two hopefully quick questions. One, when was the last time you had a full audit done of your department?
We have programs audited every year, but a full
I'm
audit.
talking about from the state auditor, an outside auditor to come in and look at your financial management decisions and processes, as well as your benefits and protocols and procedures.
I don't know the answer to that.
Like Misty said, we have ongoing audits all the time. The auditor is part of those audits, as well as the federal government completes audits of our programs, all funding. We have reporting that we do both federally and state. So, I mean, that's regular and ongoing.
Okay, that's not really financial audits or decision type of audit. Those are more nuts and bolts types of audits, correct?
Well, yes, and I think there's a financial component to all those as well.
Okay.
There is.
And one thing I want to comment, and that is, although you didn't cover it, in terms of fraud, I'm seeing a running theme in House and Family Services, various areas about program integrity. One or two sentences, what are you doing in terms of honing in on fraud issues and what the cost of that might be?
Well, as we talk about SNAP, that's part of the SNAP admin cost. I'll go back here real quick. One more, okay. Program integrity. So we have a robust program integrity. That's very important as we operate the program. Fraud detection and recovery is part of that. We were one of the first states to adopt the NAC, the National. Hang on. The National Accuracy Clearinghouse. Sorry, we talk in acronyms, and that is a system that enables us to check across states to make sure an individual is not receiving SNAP in another state before they are issued SNAP benefits in Kentucky. We have a hearing and independent audits. We have income and employment verification tools that helps us check with regards to tax information, income information, employers, et cetera, with the IRS and again, other employers. And then, again, talking about audits, the auditor, public accounts. We have also contracts and relationships with the Office of Inspector General and the Office of the Attorney General.
Okay, thank you.
Thank you. Now we'll move on to relative and fictive kin caregiver supports.
Okay.
I think you have a
Get back up here.
load for that one.
Yes. Okay. In the governor's recommended budget, it includes $14.6 million in each fiscal year of a general fund appropriation to fully implement the 2024 regular session Senate Bill 151. So, and again, I just want to state here that Senate Bill 151, we all agree is good legislation. We support the legislation, but it does create a new mandate for the department, which needs additional resources for us to be able to implement. It does come at an additional cost to the department, which we're going to talk about. So when we talk about kinship care, it encompasses a lot, and I think there is oftentimes confusion as to what kinship care is. We within the department, there was an old kinship care program, which there's been a moratorium placed on since 2013, and so I think there is oftentimes confusion around that program and what our current service array is for kinship care. So, what happens when when DCBS determines that a child is not safe to remain in the home? Then we want the least restrictive placement, which is a relative or fictive kin member. So once that person is identified and they agree for placement, they want to accept placement, then we work with them to explain what the service array and what their options are. So here's a definition of what kinship fictive kin is. I won't read that to you. You can read. But again, once a relative or a fictive kin states that they want to pursue placement of that child, we immediately connect them with a kinship care navigator. We have navigators in all 9 of our service regions, and this is their job. They know the program, they know the service array inside and out, and so they meet with the relative to explain to them what their options are, which is either the relative takes temporary custody or the child comes into the state's custody and they can go through the process to be approved as a relative fictive kin foster parent. So what does Senate Bill 151 do? It expands that decision window. Currently, that decision has to be made at the time custody changes. So when custody moves from the parent to either DCBS or the relative, that decision has to be made by the relative as to which one they want to pursue, temporary custody or being a relative foster parent. What Senate Bill 151 does is it expands that window to 120 days, or if there's a qualifying event, anytime. And again, the Cabinet supports this legislation. It's good legislation, but it does create a new mandate for the department to serve a population of children that we are currently not serving, which comes at an increased cost. And what that looks like. So we looked at this a couple of different times, and this is consistently we found approximately 1,000 children who enter a temporary custody of a relative or victim caregiver within that 120-day decision window in which the Cabinet was involved with that family. So around 1,000 children. The average foster parent per diem per day is $28.17. You multiply $28.17 by 1,000 times 365, you get 10.3. Now, children who enter care under the provisions of 151 are not eligible for any Title IV funding. And I can talk more about that, but I don't want to, if you have questions, I don't want to muddy the water, though. This is a new population of children that's being served by the Cabinet, and which creates, again, a new mandate and comes with with additional resources needed to be able to do that. And the workforce. The other piece of that budget request is to support our workforce. This is not a simple task. It's not a social worker going out, meeting with a family, doing a walkthrough of their house and checking a couple of boxes, filing a petition with the court, and then they're done. It is much more involved than that. A social worker will have to go out, they'll have to complete a new assessment. They will then have to, again, file that petition with the court, becomes court active. Then we engage our recruitment and certification team who has to certify that foster home. And then the case is also open for ongoing services. Now, the permanency, we have to reach permanency for that child, which is either reunification, so working with a biological parent to reunify. If that cannot be achieved, the next option is termination of parental rights in adoption. If the relative wants to pursue that, again, that takes time. Courts or the judges we're going to have to prove that we made diligent efforts to reunify that child before the courts are going to move forward with that TPR and adoption process. If a relative does not want to pursue adoption, the next permanency option is subsidized permanent custody, which is a new permanency option that's been available since 2024. And a relative, again, can choose that as a pathway, which is basically what it says. The relative will receive permanent custody and receive a subsidy for the ongoing care of that child while they are in their home. That takes time as well. We cannot recommend subsidized permanent custody, federal rules, not Kentucky's. We cannot recommend subsidized permanent custody until that child has been in that home 6 months past the time in which the home was certified as a foster home. So again, this is not just a couple of little additional tasks that we're asking of our workers. It is very involved. It takes time, and again, cases are going to be open up to a year or longer. So again, you're looking at the total recommended budget from the governor at $14.6 million.
Okay, thank you so much for that presentation. I think we have one question, Representative Johnson.
Thank you, Mr. Chairman. So I just want to understand, you're saying that this is a new population of children not currently being served. Does that mean these children are in no way involved with the foster care program?
They are not in out-of-home care, foster care. Currently, the relative has decided upon initial placement that they did not want to pursue becoming a foster parent, and they wanted temporary custody. So at this point, they are not in our custody. We are not paying a per diem for those children.
So when you say the relative, is that the fictive kin relative?
Yes,
that
the
would-
relative or fictive kin member, yes.
So what about the parents, regardless of having a fictive kin option, aren't these children still being considered for foster care? Or is this a whole category of kids that the parents aren't even talking about foster care unless it involves fictive kin? Is that what we're saying? I just want to understand the scope.
So the department is involved in these cases. We have determined that, again, the child is unsafe, and the relative has been identified and given the option of temporary custody or becoming a foster parent. If they choose that temporary custody route, we will work with the parents for a period of time, but that case is likely to close more quickly because custody has been established with a relative. If the parent is again not making progress, and so the case again will close sometimes more quickly.
Okay. And I'm asking this because I think we need to fully understand why there's an additional 14.6 per year when we already have a foster care program in place, and we need to understand that distinction. And I may still have more questions later, but we're running out of time. So thank you, Mr. Chairman.
Thank you. And that brings me, appreciate your presentation today. Can you get me the numbers, the actual budget breakdown of the kinship care as it, carved out of everything else, and get that back to this committee?
Yes. We can. Do you have a question?
For kinship care, do you mean the program that's on moratorium, or do you mean the relative fictive kin?
What you
budget?
budgeted to ask for $14.3 million?
Okay.
Can you break that down? What does what?
Yes.
Yes.
Okay, thank you. All right, I think moving on now, and again, thank you all for the presentation today. In our last presentation today, Steve Shannon, Jennifer Willis discuss a budget request related to the Certified Community Behavioral Health Clinics, CCBHCs. If you would come to the table, please. And if you would introduce yourself for the record, and then you would have the floor. But again, we're talking about the budget requests and how the governor's budget request is, in your opinion, what it looks like and what we need out of that money that's associated with that. Thank you.
I am Steve Shannon, the Executive Director of CARP, Association of 12 of the 14 Community Mental Health Centers, and 10 of those are CCBHCs.
I'm Dana Royce. I'm with New Vista. I serve the 17 counties in central Kentucky as a CMHC and also a CCBHC since January 2022.
Ms. Willis was snowed in. She could not try to make her trip from Ashland and could not get here. So we appreciate Dana Willis, Lord have mercy, Dana Royce for stepping in. She's going to talk briefly, and I'm going to keep saying briefly, about what a CCBHC does. Then I'm going to delineate the funding request.
All right. Thank you for letting us speak today. The Certified Community Behavioral Health Clinic, or CCBHC program, is one of the most significant pieces of behavioral health legislation of our generation, on par with the original Community Mental Health Act of 1963. CCBHCs are required to serve anyone, regardless who needs behavioral health care, regardless of age, ability to pay, or where they live. To ensure truly comprehensive care, CCBHCs must provide 9 core services. Many of these CMHCs have always done in our long history, but there are additions and expansions. Those 9 services are crisis mental health services, including 24-hour mobile crisis teams in coordination with 988 suicide and crisis lifelines, screening, assessment, and diagnosis, treatment planning, outpatient mental health and substance use disorders, outpatient primary care screening and monitoring, targeted case management, psychiatric rehabilitation services, peer and family support services, and then prioritizing outpatient behavioral health care for our veterans. The most significant shift from traditional community mental health services is the addition of mobile crisis teams, primary care screening and monitoring, and along with care coordination. Mobile crisis teams operate 24 hours a day and are embedded in our communities. They respond directly to people's homes or anywhere support is needed, assessing individuals in crisis and determining the appropriate level of care in real time. Primary care screening and monitoring occurs for every person served by CCBHC. This is where the handoff to care coordination begins, and care coordination is truly the linchpin of the CCBHC model. It is a required service and a major driver of the improved health outcomes. Care coordination brings together internal and external providers involved in a person's care. It is a collaborative, ongoing partnership that ensures care aligns with individuals' needs, preferences, and goals, and is truly transformative. We know that people living with severe mental illness or substance use disorders die 25 years earlier than those without. Care coordination is designed to address this disparity by integrating physical health, behavioral health, and social supports, helping people live longer, healthier, and more productive, fulfilling lives. The key responsibilities of care coordinators include scheduling and following up on appointments with primary care, dental, specialty, and all behavioral health providers, providing health education and patient navigation, supporting medication management and adherence, referring individuals to psychiatric, behavioral health, or opioid treatment services, assisting with transportation, and connecting people to the community and social services within their local community. When someone is discharged from a hospital, emergency department, inpatient behavioral health setting, or any higher level of care, the care coordinator ensures follow-up appointments are scheduled, medications are continued and reconciled, and providers are notified of changes, the discharge instructions are understood, and transportation and other barriers are addressed. CCBHCs are transforming community behavioral health systems by delivering coordinated, high-quality mental health and substance use care while significantly expanding access. Over the past 4 years, CCBHCs have demonstrated improved access to care, a higher number of people served per clinic, increased independent licensed provider staffing, stronger care coordination, and expanded provider networks. Care coordinators play a critical role in synchronizing the care across multiple providers, ensuring services are seamless rather than fragmented. They maintain regular contact with individuals, often by phone, building that trust over time. As people open up about changes in their physical and behavioral health, care coordinators are there to continue to connect them to the appropriate services and supports that they need when they need it. CCBHCs provide value with new and enhanced services by providing those services more upstream before the crisis occurs, and obviously before higher expensive levels are accessed, and that's where we see the value. Thank you.
Thank you, Dana. I've been doing this way too long. Representative Wilner will attest to this. We have spoken about the need for integrated care. Many models have been proposed for behavioral health and physical health. This is integrated care. CCBHCs don't provide the physical health care, but they make sure it occurs. It's a profound change in our industry. We've moved from talking about it to have a tool to implement. I'm going to tell you how we got to this budget request. In August, we had a meeting with Commissioner Lee, Medicaid Commissioner Lee, and Behavioral Health Commissioner Marks, and we were advised then that currently the CCBHCs is a demonstration project at the federal level. And during that demonstration, the CCBHC and that spending has an enhanced match rate. Okay, so it's a better deal for the Commonwealth. It's an incentive to do CCBHC. That enhanced match rate ends December 31st, 2027, okay, which is the 3/4 mark of the next biennium. So we now have a match cliff, funding cliff, effective 1/1/2028 through the June 30th, 2028 period. That 6-month period, because the match rate changes, right? So match rate, we spend 20 cents, feds give us 80, we get $1, now it goes to 30.70. So we have to make up that difference. And we were kind of told, go ahead and do this. So our action was one, Moab. Many of you serve on Medicaid Oversight Advisory Board. It's a great PowerPoint on CCBHC on their webpage. Much more information than we're going to give you today. But that was the first presentation. We talked about it. Similar information. We also included, thanks to the work of Dana Royce and myself, primarily Dana, the funding amount. And what we came up with was $12 million, state general fund, in fiscal year 28, primarily for that last 6 months. And how we got that number. I think before this committee last February, Medicaid presented the top 20 spend by provider types. CCBHC was number 17 of the top 20, about $117,297,000 for fiscal year 24. That was our base number. All right, so that's what we get, right? We know that. We know the four, the initial ones. It was 7 counties in Louisville, CEOs here. Northkey, Northern Kentucky, representative leadership's here. Pathways, Ms. Willis is watching on TV, and Ms. Royce. They presented on that information, share that information. So we took that 117 million figure, said, all right, half of that is roughly 58, 59 million. That's going to be the last 6 months. Again, we acknowledge this is 24, but this is a real number, not our number. We wanted to use a real number that's been presented at the General Assembly, and we went back and said the last 6 months is 59 million. So how much do you need to maintain 59 million with the federal match rate going to the traditional match rate? It's about $6 million. You could say maybe it's $6 million. So $6 million is needed for those four. Since then, 6 more have been added. They're just starting. They need to have assurance that this is going to sustain itself through the next biennium, as opposed to saying, sorry, we can't do this because we didn't get the money. So we took that, about 57% of the population, we added that, again, just guesswork, another $6 million. It may be 11.2, it may be 12.4. But our number that I can come to the table and explain the math, and if I can't explain the math, I don't want to come to the table and talk about numbers, is $12 million. So we're asking for $12 million in fiscal year 28 to make up for that change in the match rate at the federal level. What does that $12 million get you? One, we're not getting paid any more money than we are now or will be in December of 27. It allows the programs to sustain itself. So it's just not the 10 that are sustaining. The care coordination is sustaining. The upstream efforts Dana Royce talked about are sustaining. That is what we need, and it's $12 million for fiscal year 28. That was our assignment. That's what we said to Moab, Medicaid Oversight, finding 11. We're a fragmented behavioral health system, not integrated with physical health. First recommendation, expand CCBHC statewide. It addresses fragmentation and integration. This is a fix that we can ensure the next biennium for $12 million and then maintain it going forward. That's the real objective. That's what we want to see happen. It changes people's lives for $12 million.
Thank you so much for that. Do we have any questions, remember? We have one for Representative Johnson, please. Go ahead.
Sorry I'm being so repetitive on questions today, Mr. Chairman, but this is important stuff if we're going to get the budget right.
Yes,
so my understanding is that the current funding you have is for 4 facilities.
It's now 10.
4 programs.
Yes.
But
River
the
Valley.
new is 10, right?
Yes, it was 10. It was 4 initially. They went operative. They started January 1 of 2022. 6 more were added in December, going live January 1 of 26. So they're 5 weeks in. But we have 10 now. My goal is to get every county in this service because it's so invaluable. Right now we have 10.
So is the funding that you're requesting to fund the 10 going forward?
In this,
The additional 6?
yes,
plus
in
the
that
4.
really this fiscal year 28
For 6
period
months.
for 6 months only, because that's when the match rate drops. So we go from 20 cents to 30 cents.
So going forward, would we anticipate this at 12 million being an ongoing request going forward?
It'll actually be 4 times that for the biennium because that's only for 6 months. So it'll be 48 million. That will be, and we'll have better data on the spend. So the next biennium, it will be that number. Again, this is based on 2024 spend. But yes, that's the answer. We have a 6-month problem the next biennium. We'll be back again afterwards.
You're just not ever going to go away, are you?
No.
Thank you, Mr. Chairman.
No.
Any other questions? We have one question, Representative Fleming.
Thank you. Steve, I know you when you came to Medicaid Oversight Board, we talked about outcomes and measurements and so forth. what shape will that take in the form of, and then who will be presented that information, so we can ensure that things are coming to fruition.
Yeah.
And so we can look at, all right, 12 million in the back half of the biennium.
Mm-hmm.
Okay, well, what could you help me out with that?
You want to talk about the data you submit?
I can. So we do have required data that is required to be submitted to the state, who then sends it to the federal, and it's important information. But it is not truly outcomes to individuals. And what the 4 centers who've already been doing this are, we collect our additional outcomes beyond that. Like, what are the things that are actually improving care and making a difference in people's lives, not whether or not somebody got a depression screening, because that's really what SAMHSA is requiring at the federal level for us to report on. So we're taking it a step further to making sure that there's value for the services that people get and that there are outcomes. So I have a few, and I have a handout for anyone that's interested in that, just to really talk about what the 4 CCBHCs have done in the first 4 years. So we've increased the number of unique people we've seen by 11.25%. That doesn't seem like a lot, but actually in a 2-year period, 50% of the people I see in year 2, I never saw in year 1, right? So people get the treatment when they need it, but it's not lifelong for populations that don't need that. The SMI for serious mental illness care, we've expanded our services in that area over 30% from previously with this additional CCBHC model. We've had a 68% increase in the crisis response, the mobile that we can do in the community. Really, that's just from having the capacity to do that.
I don't mean to interrupt you. Those are good statistics. I'm trying to get down to the nitty-gritty of things. You said you see people, great. You've had a significant response. I'm trying to figure out the individual, and you said that it may be hard to individual. We need to find where the rubber hits the road in terms of individual being receiving the benefits of what your efforts are. That's what this panel wants, and that's what we need in order to help fund your $12 million. We've got to have some rubber that hits the road type of data to make sure that this is happening.
Right. So SAMHSA has already reported for every dollar invested in CCBHCs, and this is nationwide, there is a $3 to $15 return. So minimum $3 return on every dollar, and that is because you're preventing, kind of future costly systems. Some of those are behavioral health, but not all of them. That can be an impact in the corrections and other systems in the community that people access that are taxpayer funded.
Yeah. Local law enforcement, because we're going instead of they're going on the mobile crisis.
Additionally, hospital, for every 72-hour hospital in a state hospital, it's costing roughly $3,300. So if we're providing care upstream, diverting from those higher level of cares earlier, we can save money on other systems, and then reserve the what we have available to serve the people who need that level of care at that time.
I appreciate it. I think it'd be I guess it might solidify in people's mind if you actually have testimonies. I've received this, that, and the other, and it puts a little more meat on the bone, if you want to call it that. That's
we
what
can
I'm
do
trying
that
to get to.
by a large number.
Yeah, somebody would say, I did 6 visits to the emergency room before I started this program, and now I've not been back to the emergency room. Those are the statistics we like to see.
Or I didn't leave my house for 3 years.
Right, even better.
And now I'm going out in the community.
Yep.
That's a
I'm
Jennifer
glad you're out of
Willis
your house
story.
now.
What?
That's
I'm
right.
glad you're out of your house.
That's a Jennifer Willis story. But maybe with this weather, they're not going out.
Yeah. All right. Well, we thank you for coming today. We thank you for the program that you do. I think it's a good program. We're just, like we said, we're really digging into the budget and see what we're funding, and we want to make sure we're doing things right. So, if there's no other questions, would I have a motion for adjournment? All in favor, say aye. All opposed? All right, we're adjourned.